My name is Erin Feldman. I'm the Dietitian for the Pediatric IBD and Digestive Diseases Department at Cedars Sinai Medical Center in Los Angeles. Today I'm going to present the DINE-CD study, a randomized trial comparing the specific carbohydrate diet to the Mediterranean diet in adults with Crohn's disease. The purpose of the trial was to compare the effectiveness of the Mediterranean diet and specific carbohydrate diet to resolve symptoms and inflammation among patients with Crohn's disease. The study diets have some common traits and some major differences. The specific carbohydrate diet includes unprocessed meats, poultry, fish, shellfish, and eggs, most vegetables, most fruits and nuts, and some legumes. It excludes grains, dairy other than some hard cheeses, and homemade yogurt that's fermented for 24 hours, and sweeteners with the exception of honey. The Mediterranean diet includes high amounts of olive oil, fruit, vegetables, nuts, and whole grains, moderate amounts of fish and poultry and wine, and limited amounts of red and processed meat, added sugars, and sweets. The study design included a 12-week parallel group randomized clinical trial comparing the Mediterranean diet and specific carbohydrate diet. The hypothesis was that the specific carbohydrate diet is superior to the Mediterranean diet to achieve symptomatic remission, clinical remission, and reduction in biomarkers of inflammation among patients with Crohn's disease who have mild to moderate symptoms. The main inclusion criteria included a short Crohn's disease activity index score between 176 and 399. The participants also had to be on a stable dose of medications at screening. The key exclusion criteria included pregnancy, ostomy, known symptomatic intestinal stricture, use of specific carbohydrate diet within 4 weeks of screening, greater than 20 milligrams of prednisone or equivalent, or recent C. diff colitis. The trial included adult patients with Crohn's disease with mild to moderate symptoms who were randomly assigned 1-to-1 to consume the Mediterranean diet or specific carbohydrate diet for 12 weeks. 93 participants were randomly assigned to consume a Mediterranean diet and 101 to the specific carbohydrate diet. For the first 6 weeks, participants received prepared meals and snacks according to their assigned diet. After 6 weeks, participants were instructed to follow the diet independently. They did have the option to purchase their meals, but most of them declined. 460 participants were screened for eligibility, and they identified 197 who could be randomized. 3 people dropped out before starting the study, and a few who needed to be excluded due to a technical error. 191 participants were included in the study in the end. Outcomes were measured at 6 and 12 weeks. The primary outcome measure was symptomatic remission, defined as SCDAI score less than 150 in the absence of initiation or increase of any Crohn's disease medications. The key secondary outcomes were fecal calprotectin response and C-reactive protein response. The week 6 outcomes showed symptomatic remission was achieved by 43.5% of the participants on the Mediterranean diet, compared by 46.5% on the specific carbohydrate diet. Clinical remission was almost identical to those with symptomatic remission. Reduction of bowel inflammation was measured with fecal calprotectin, and CRP normalized in a very small percentage of patients. None of the p-values were statistically significant. At week 12, participants were obtaining their food on their own. The results were fairly similar to the first 6 weeks. None of the outcomes reached traditional levels of statistical significance. In this randomized control trial of patients with Crohn's disease and mild to moderate symptoms, the specific carbohydrate diet was not superior to the Mediterranean diet to achieve symptomatic remission. In conclusion, despite increased consumption of fruits and vegetables, both diets were well tolerated. While there was improvement in symptoms with both diets, the specific carbohydrate diet lacked superiority relative to the Mediterranean diet to achieve symptomatic remission at 6 or 12 weeks. Given the high rates of symptomatic remission, it's not surprising that participants in both treatment groups demonstrated improvement in quality of life measures. Neither diet was associated with normalization of CRP concentration. Either diet may be tried to improve symptoms of patients with mild to moderate Crohn's disease. Based on the results of this trial, the greater ease of following the Mediterranean diet, and the other health benefits associated with the Mediterranean diet, these results suggest that the Mediterranean diet may be preferred to the specific carbohydrate diet for most patients with Crohn's disease with mild to moderate symptoms. And it's important to assure that inflammation is resolved even if symptoms improve.